Thank you again for having me here at the conference, and thanks to Cheyenne also. It's always a pleasure speaking here in front of a large group of people here. My name is Jay Granzow. I'm full-time faculty at UCLA, and I'm here to talk about integrated surgery and therapy system for lipedema patients with lymphedema as well. Okay, I have no financial disclosures. What's most important to me is that this is a team approach for us. So we have a lot of people in our office, staff, hospitals who we rely on tremendously. It's not just about me or some surgical procedure. It's about the whole process that everyone goes through to get our best result. Here again, I thank my family more than anything. Amy is actually here, and I think many of you have met her during the process here. We've had a lot of changes, as you know, probably from last year if you've come, with our daughter's health too, and so she stopped her work she's now a recovered attorney, but she does help navigate the insurance and everything with us in the office as well. So key points that I want to go over are lipedema patients often present with lymphedema as well. So not every lipedema patient has lymphedema, but many of the principles apply, and more patients do have lymphedema than is apparent at first. So for me, the patient evaluation includes a lymphedema assessment as part of what we do. It's very, very important, because if you miss that lymphedema assessment, or if they have components of swelling that need to be addressed, those will complicate the healing process and make those things worse. Brianna was gave a fantastic talk earlier, and the thing she talks about with swelling, those are very important things that we address as part of the whole process. Treatment, if patients do have lymphedema, that will significantly affect your treatment plan, and the treatment for patients with both lipedema and lymphedema will be substantially different than with just lipedema. Just briefly about me, so I'm board certified in plastic and reconstructive surgery. That's since 2006. I have actually did two residencies, had two board certifications, additional 2 fellowships, one of which is in microvascular surgery, the other one is actually in aesthetic surgery, and I had some additional visiting fellowships. I'm currently on full-time faculty at UCLA, and I have a private practice separately. The private practice is where I do essentially all the lipedema treatment and a lot of the lymphedema too. So this all began with me in Japan in 2005. One of my visiting fellowships was with Dr. Koshima, and that's where I started my lymphedema journey. And so here we're doing a microsurgery procedure on lymphatic venous anastomosis, which is connecting vessels that are anywhere from 0.1 to 0.7 millimeters in diameter to the veins to help lymphedema drainage. And that progressed to lymph node transfer, suction for lymphedema, and then lipedema as well afterwards too, bringing in the different components. I don't have time for, and I won't be able to fit in what the difference is between lipedema and lymphedema. Major differences are lipedema tends to be more of a disorder of pathologic fat and connective tissue. It's symmetric, and the fatty deposits are usually painful compared to, when you compare it to lymphedema, which is a disorder of the lymphatic circulation. So there's fluid that circulates, it helps clean your body. When that gets blocked, you have a problem. It's always asymmetric in one arm or one leg. They're going to be affected differently, even if both sides are affected. And the diagnoses are clinical on both sides. So, for example, here's a patient with lipedema, more mild presentation. Again, symmetric presentation on both sides. Lipedema, here's a slightly more affected patient again. Symmetric presentation, similar pattern. This one's lymphedema. Okay, I picked a more extreme example. This girl is in her late 20s, had it as a congenital case rather than post-cancer. You can tell which leg's affected. This patient had a cancer, was treated, GYN cancer, left leg more affected than right. Again, these are very different entities that sometimes do overlap. We can get MRI scans as part of our treatment process, and these are all patients that I've seen and taken care of. This is the unaffected side, it's the small one, the affected side is the big one. And even in patients that don't seem like they have a lot of fluid going on in their lymphedema, when you actually image them, you see, and all those white strands and that white glowing, the white things that are up around, that's all fluid in there. And that needs to be treated, and that's why the decongestion and the therapy component of our process is so important. Okay, so if they're both, can lymphedema and lipedema be present in the same patient? Yes, and so the preoperative evaluation is very, very important. Patient history, possibly lymphoscintigraphy, and intraoperative lymphatic mapping. I spend an hour with a new patient. Our therapist spends 1 to 2 hours with the new patient. That's part of the overall evaluation because we're pretty thorough. We want to be as thorough as possible to take care of that patient. I don't rush through things. And because, again, the treatment will be very different. The treatment for lymphedema is much more intense than lipedema. The lymphedema treatment will treat lipedema post-op, but the lipedema won't necessarily treat the lymphedema post-op. Okay, and for example, this is a patient that we take care of recently. She comes with a mild version of lipedema, but turns out she has lymphedema as well in the right leg. And you can't just tell from the photograph initially. Okay, lymphoscintigraphy, I won't expect everyone to know even what's going on with these images, but I know that I'm very used to reading these. This is a typical lipedema process where you see more of an inflammatory image versus something that's lymphedema where you see a lot of backing up of the fluids, especially down here in the bottoms of the legs where you can really see the outlines of the legs where those lymphatic channels have been badly damaged and the lymphatic fluid is just trying to find its way up. And why is this important? Well, here's some of the aspirate from a case from the water-assisted liposuction, and the aspirate here is a nice, creamy, sort of custardy stuff on top of a lot of fluid because that's how the wall or the water-assisted liposuction works. This is lipedema. This is how lymphedema aspirate looks, or often looks. It's a very different animal. This looks like curdled milk compared to the nice creamy custard on the left side, and because it's different material in there. The fluid is inflammatory, it damages the tissues, and it's very different, and the one has to be treated differently than the other one too. So how do we treat lipedema? It's a system. I won't get caught up in any of the details because we don't have time, but patient evaluation is really, really important. And patient selection. So we can use wall, we can use this suction-assisted lipectomy or the power-assisted liposuction as well. We can use local anesthetic, we can use general anesthetic, depends on the patient. And each patient is different, and we go over each patient's process individually. Again, this is a system. I've gone and visited Dr. Stutz in Germany and also Dr. Roprich in Germany. They do it differently. Dr. Stutz uses a water-assisted, Dr. Roprich uses a tumescent technique. They've both taken care of thousands of patients also. They both work, depends on the patient. So, again, and with our lipedema process, this works. And we can treat volumes, or I have treated volumes everywhere, anywhere from 500 to 10,000 cc's. It depends how you do it, and you can do it safely. It just has to be handled correctly. Here's an imaging that I've done in the operating room to help avoid those lymphatics. But I know that also when we do these procedures that it's safe for the lymphatics. I've personally operated on them under the microscope. I've imaged these things, and it's important. So again, how does this, and a couple examples. Here's that patient with a more mild lipedema before and after. Here's one that's more advanced. And so we'll go for the cosmetic aspect too, don't get me wrong. I think I'm very much about treating that, but the symptoms and the function are usually what the patients come to us about. Okay, so how does lymphedema differ from this? And lymphedema therapy is more intense. The compression garments will be needed for a longer time, possibly even lifelong, depends on the patient. They may need overnight hospital stay with their lymphedema surgery, which is typically more intense as well. And then I do the microsurgery procedures as necessary too. The bandaging happens on most of our patients with lymphedema. Our therapist comes into the operating room and bandages the entire leg, especially, and takes care of that because that swelling is so much more intense in a lymphedema patient. We also have a system for lymphedema therapy. It's different than the lipedema one. There's more going on. The therapy component is more intense. We take out the solids, which are different, and then we add the microsurgical procedures, which are the high-power microscope, et cetera, as needed as second stage procedures sometime. So again, this is that slide I showed you before. Here we're working on the right side, which is that more intense stuff that's there. And the suction procedure for that is entirely different than a lipedema procedure. I mean, this is in the hospital with a tourniquet. You have to do this to get that solid out, or you won't get it out and you won't achieve the result that you need to with a lymphedema patient, different than lipedema. And again, bandaging afterwards, this is one way the patient may appear. But that allows us to take a patient like this and achieve a result like that. You can't get this if you don't have those intense things. We've tried it all the different ways back since, again, we've been doing this for a long time too, and if we don't approach this more aggressively, you can't achieve this in a long-term way, in a meaningful way, in the same way with a lymphedema patient. This is the rear view here. And this is the patient, again, who had congenital lymphedema, so never in her adult life before could she wear jeans or boots, and she's shooting selfies in the department store afterwards. And we love getting these pictures from the patients, so that's very important. Again, these are images that I've taken of patients. The lymphatics before do well, and they look at least the same, if not better, after our procedures. Even that intense lymphedema procedure, the lymphatics are spared. In fact, they're usually better. And that's been reproduced by other colleagues as well, using similar imaging techniques, and we can image this on lymphoscintigraphy or there. A couple final notes here. Other procedures that I do will be lymph node transfer or lymphatic venous anastomosis, which is, again, a fancy way of saying lymphatic connection. So there's a little lymphatic under the microscope, and this is an ophthalmology microscope, which I've co-opted into a lymphedema microscope. Turned around the eyepieces, and so we've taken a 0.3 millimeter vessel, connected it into the vein, and you can see the dye going out there. And so if you have the right patient at the right time, this will work. Lymph node transfer here. This one, I don't know how to tap it to make the video work. Did I go back? Middle one? Perfect. And so if you're taking a lymph node, you're going to take some surrounding tissues. Here I've imaged that lymph node. It's glowing under the skin right there. There's a little forceps, and we take that with an artery and a vein. We plug that in, and that helps drainage too. And so again, for those patients that do have the lymphedema, we can treat them very effectively. And I'll end again on a personal note with our daughter. I brought this up last year too. So our family isn't just on the provider side, we're also on the patient side. And our daughter was diagnosed last year with something called Angelman syndrome, which is a deletion in one gene on one side of one chromosome that gives her a pretty bad outcome. And so it's a rare disease, just like lipedema is a rare disease. And one thing that we've really come to appreciate, and I think this is why a forum like this is so important, and I think we're really very grateful to Cheyenne and Felicity and everyone for putting this together, is that I think you're going to get a much better idea of what happens with lipedema treatment from this forum and from the people you meet around you than you are from your local physician and the people and other people who just don't have as much information. We found the same thing. We have a child with a rare disease. We had really bad advice. We were told she would never talk, she would never read, she would never write. She would probably have seizures and may never walk properly. And you know, a lot of those things are turning out not to be true. There's a little iPad right there that she can start to communicate with. She actually found the golden egg this year at Easter, and so from the regular kids too, so that was really great. And I think there's a lot that we've learned, but we've done that from the patient groups and from learning and connecting with clinicians who we found through that other patient group rather than just local physician. And me being a physician, it's even more frustrating to be given a lot of bad advice locally. So talk to the people around here. Very, very powerful. I think you can see that you're not on that journey alone, and there's a lot you can really accomplish to make your outcomes much, much better. So again, for us, if you want, come visit us in California here. The door is always open. You can find myself, Amy, everyone here as well. I'm very happy to go over things, or we can talk on the phone or per email. And if you have more, if you want to get more information, you can certainly always get in touch with us. Thanks very much.